Sri
Good
Ganesh.
afternoon, dear friends, and thank you, Partha, for inviting me to this hall-packed, jam-packed IC. Congratulations.
Thank you.
I'll be sharing a few of the situations. Of course, there are not many situations, and they're quite common, like flip lenses or ICL exchange, and so there is some amount of overlap, but I'll be showing you some of the challenging cases that I've had in the past. I've been doing ICLs for 11 years now, more than 2,500 lenses. This is a case of ICL exchange. As you can see, this is a low myopia, and the white to white was 11.9, and then post ICL we found that the vault is very high, 1,570, and the angles were very narrow. This is ASOCT showing very narrow angles, and the UBM, we did a UBM and it showed sulcus to sulcus diameter of 11.3. So I decided to exchange the original lens and put two lenses lower and use a 12.1 instead of a 13.2. And this is my technique of how we went about it. The biggest challenge with ICL is sizing, because if you get a very low vault, then you have a higher incidence of cataract. If you have a very high vault, then you can have progressive angle closure and then glaucoma. So if you have a high vault like 1,500, then definitely don't wait even if the intraocular pressure is normal, because progressively over a period of time it can get worse. So I go and open the incision, 2.8 incision. Then you can see what I do is, as I'm injecting the xylocaine, I just engage the hole there and then lift it so that it comes out of the sulcus into the antechamber. And then I rotate it gently. Now what Star says is that you do a hand-over hand technique. You grab the edge of the haptic with forceps, pull it, and then do a hand-over hand. But I find that this technique is better. I rotate it. The optic-haptic junction is the thickest part of the ICL, so it will not tear if you grab it there. And then you can just grab it there and pull it out. If you hold the haptic, there is a chance that you can tear the haptic, and many a time it happens with the hand-over hand technique. So this is a much better technique and very easy to follow, and always grab it with the optic-haptic at the optic-haptic junction, and you can use the same forceps. And this is the reintroduction of the new smaller size, 2 sizes smaller. So this was actually a surprise, an anatomical variation. Normally the sulcus to sulcus is bigger than the white to white. In this case, the sulcus to sulcus was smaller than the white to white, so there was a problem with sizing. So maybe it is a good idea to do UBM in all cases. The exchange rate may be anywhere from 2 to 5%, but now I have started doing a UBM in all cases, and we find that sometimes you can have anatomical surprises. Even between eyes you can have difference in measurements, and the white to white does not always correlate with the sulcus to sulcus. The angle to angle is a better measurement, and then you should probably look at that also. And there's a study by Alfonso which shows that angle to angle correlates better to the sulcus to sulcus than the white to white. So just doing the white to white measurement may work in about 80% of the cases. Sometimes you get huge surprises in vault and you may have to do an exchange. So this is typically how you go ahead and do an exchange. This is a V4C lens. This is a post-op vault. You can see that it is 400 microns, which is the ideal vault. 2 sizes less than what we had originally selected, and the angle has also opened up very nicely. And this was the post-op picture, first post-op day. Cornea is quite clear. This is another case of ICL flipping. This is something that can happen, and ICL flipping is more common, I find, with the V4C, because you have a hole in the center and that kind of weakens the central area. It's not as stiff. So as I'm injecting, you can see it rotates. I try to flip it by rotating my wrist and rotating the injector, but that does not happen. Now if I inject viscoelastic here, it's going to flip the wrong side. So you should be careful as to when and where you inject the viscoelastic. So I go in there and then as I inject the viscoelastic, even with the cannula, see, I inject viscoelastic, deepen the chamber, and with the cannula itself I nudge the lens, and I'm able to gently flip it over. You can do this maneuver. If it completely goes inverted, then you don't try to flip it. If it's completely inverted, then you will have to remove it and then reload it and then inject it. You can also use the central, what you saw there was I used the central hole to get a purchase on the lens so that I can push it. Otherwise it's very smooth. Then once you have flipped the lens, then you can go in and then very easily tuck the haptics. I use only a single side port to tuck the distal haptics, and I tuck the main, the proximal haptics to the main incision. And then you can center it. So this was a common problem that can occur if you load the lens properly, looking at the orientation, inject slowly and steadily, look at the direction, see how it's unfolding, rotate accordingly, and then you can manage. This was another case where the patient came with a refractive surprise. We had put in a toric ICL and we found that the ICL had rotated almost 90 degrees. It was supposed to be in the horizontal axis, and you can see here it is rotated completely into the vertical axis. He came in after 2 months and then he gave history of eye rubbing. Then I thought, okay, we are going to reposition it. It's a simple procedure, so you need not open the main incision. You can just go through the side port, put in viscoelastic, or even under saline you can rotate it. Here I have rotated it here, and then it's in position. It's almost in the horizontal, maybe like 5 degrees or so was the orientation. I just check the orientation, rotate it, see that it's in position. The point I want to highlight here, I'll show you the video, interesting. Now you can see that it is rotated in place. I again recheck the measurements. The measurements are okay. The vault was fine. The vault was about 600 microns, which is ideal. So sizing was not an issue here. So I thought, okay, the patient has rubbed the eye and maybe it is kind of rotated. He's a high myopic astigmatism. So again, recheck. It's seated correctly, oriented in the right position. And so I go ahead, wash out the viscoelastic and think I can close it. But what you should realize is these very high myopes, the sclera is very compliant. It stretches, so the sulcus again can change. And here I am forming the anterior chamber. I inject saline. I am hydrating the side port, and then again rechecking. I find that again the alignment is fine. The lens is stable. Then I think, okay, I'll make the wound a little more tighter. I just check. You can see it's soft. So I go in, hydrate a little more. Watch carefully what happens. Did you see that? Watch carefully again. As I'm hydrating, the lens rotated into the vertical position, because the vertical sulcus to sulcus is the largest and the horizontal, it's much bigger than the horizontal. So the sulcus is basically vertically oval. The largest diameter is the vertical sulcus to sulcus, not the horizontal sulcus to sulcus. So the lens has a tendency, if the eyeball stretches a little, to rotate. So I re-rotated it, put it in position, waited, but again there was a rotation, so I had to exchange this lens. Though the vault was fine, what happens is when the sclera stretches, the sulcus, even if it changes a little, then the lens will rotate into an area where it has the maximum diameter, which is the vertical diameter. So this is the case where that happened, and then I had to exchange the lens. This also brings about a new question. Why not we put the lens so that it is oriented vertically? Because star typically says oriented horizontally, and the white to white is largest horizontally, but the sulcus to sulcus is largest vertically. So if you put it vertically, a toric lens vertically at the largest sulcus to sulcus, then there is no chance that it can move. It will not move into a smaller sulcus to sulcus area. It always moves into the larger sulcus to sulcus area. So that is something that we can look at, whether we should actually measure the vertical sulcus to sulcus, order the lens for that size and place it like that. Maybe it will be more stable. Thank you very much for your attention.